Insurance isn't healthcare. So what is insurance? It's a financial instrument, right? It's a hedge. It's a financial hedge against unforeseen catastrophic loss. Primary care should never have been glommed onto a catastrophic insurance thing. So this is like a fundamental oppositional thing.
Welcome to How I Doctor, where we're bringing joy back to medicine. In 1998, a young internist named Dr. Jordan Shlain walked out of a business meeting in San Francisco furious. A colleague had backed out of a deal at the last minute. Jordan needed to blow off some steam. He wandered into a cafe. That cafe happened to be in the Mandarin Oriental Hotel here in San Francisco, and he noticed a stream of well-dressed guests coming through the lobby. So he walked up to the concierge desk and asked a simple question. Who's the doctor here for the hotel? There wasn't one. 2 weeks later, he comes back with something that looked like a medical chart, his med school transcript, his residency records, letters of recommendation, and talked his way into becoming the hotel's on-call physician. That one conversation became a business. And in 2002, Jordan founded Private Medical, now one of the longest-running concierge practices in the country with more than 1,000 member families across 6 cities. Jordan is a real doctor's doctor. He's also become one of the concierge medicine's most direct defenders. The New England Journal of Medicine just devoted an entire piece to asking whether his model and models like it actually have something to teach the rest of the primary care system that's maybe collapsing under its own weight. I'll be right back with Jordan after a quick word from our sponsors. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. The next generation of physician innovators are already thinking hard about AI in clinical practice. Off-Call teamed up with MD+, a nonprofit community of physicians and med students across the country, to write the guide I wish existed when I started trying to make sense of all of this. It's called The Physician's Guide to AI, a practical primer across specialties. 9 specialties, 40 plus physicians, and it's completely free. Search for it now in the Kindle store or visit offcall.com. Dr. Jordan Shlain, welcome to How I Doctor.
Thank you, Graham. I'm excited to be here.
I think concierge medicine sometimes has a rap of maybe focusing on VIP and managing things almost too much control to a fault, but you really care about getting the medicine right.
I think it's all about getting the relationship right and putting the medicine in context. The current system was built for institutions, not for people, right? We just have to be clear on that. Once you went from the house call to the hospital, hospitals are institutions. There's a whole P&L. There's spreadsheets. People have to, people take care of spreadsheets in hospitals. So, bringing back the doctor-patient bit is fundamentally why we all go into medicine. It's a calling.
Yeah.
Nobody wakes up and says, I want to go into medicine so, I can make a lot of money. I mean, I think people think that, but now you become a programmer and agents or AI, do something. Money's not where it's at, but, a certain percentage of people, they're born and their character is I want to help people. There are people that want to, hunt. There are people that want to gather. There are people, if you look at old societies and tribes, there was always one person that had a role in that little group. And so, whatever percentage of the people that go into medicine is because they care about people. And fundamentally, how do you bring that back? We have to distill what we learned, and then we have to take our body of knowledge and experience and try to come up with a plan to help address a malady. This is in the broke, fix, sick care system model. The moments that we're in and the questions that you asked really get to where are we now, and how do we move from this system that I don't think anybody likes,
Yeah.
Doctors don't like it. Patients don't like it. I always said that an unhappy doctor is an unhappy patient. And
Yes.
how do you bring these things back to how do you bring humanity back to this? I'll go through a couple of, as we do this interview, a couple of aha moments
Sure.
that like really changed the way I thought about it. And one of the aha moments I did a couple of house calls and people paid me in cash at the time, or there was no credit card machines or Square or any of these tap things, but they would give me like $300, $100 bills. And with pleasure, I'd go to the hotel and I'd see them. I'd listen to their heart. I'd maybe give them antibiotics, whatever I would do. Um, and then I thought, like, in the office that I was just at, like, people were paying tug of war with a $5 bill at the copay booth,
Yeah.
and I was like, why would someone not want to give $5, which is inconsequential, and yet somebody would want to happily give $300? Like, what was that all about? And the aha moment was value. They saw the value in coming to attend to them when they're vulnerable in their environment on their time, and there was no, "Hey, I gotta go. It's 15 minutes." You attended to it, and I think that's what medicine really should be about, is how do you attend to it?
I do really agree with you that doctors are doctors still to this day remain the face of healthcare or medicine. And there is a feeling that the doctor is in charge and what the doctor says goes. And generally, in a lot of parts of healthcare, that is no longer the case. And so we have the blame as the person who's supposed to, I think a lot of patients think the buck stops with the doctor. And for a lot of places where you're employed by a health system or private equity or whatever, that actually is not true. The buck does not stop with the doctor.
Well, what's interesting is, perception is reality.
Yeah.
If the buck stops with the doctor in perception, then it's real. I mean, I'm sure some doctors say, but they'd be a broken record if they say, "Hey, look, I'd really like to prescribe you this, but I can't. The
Yeah.
insurance company
Yeah.
only prescribe you that." They say, "Well, can't you do a prior authorization and go through the?" Well, it's like, well, do you want me to be a doctor? Or do you want me to be an administrator? Like, and ultimately, there should be support staff to do these things, but the cost of a human, and now they're agents and stuff, but as soon as you build an agent to do that thing, then the insurance company's gonna build an agent to, spy
Anti do
versus
that
spy.
thing.
It's
Yeah.
spy versus spy, like there's no way around it unless you take a big step back and say, what if, you know, we could start from scratch? What's really important, and I'll quote a Persian poet from yesteryear called Hafiz, and he said that the words you use become the house you live in. It's kind of a paraphrase from one of his poems. And I think that the language we use around healthcare was one of the biggest constraints. I mean, we built this structure with which to talk about this thing, and if we change the language, we change the structure. I think that if I asked you, and I do this a lot, I ask a lot of people, what is your definition of healthcare? And I had you write it down. One sentence, as short as possible. If you ask 50 people, you will get 50 answers. So then the question becomes, if 50 people have 50 different definitions, how can you have an honest conversation about what you're talking about? If I put my glasses here and say, what are these? We can all agree these are green glasses, and then we could talk about them. But if you say, what is healthcare? And it's like this Picasso, Monet,
Amorphous. Yeah.
amorphous thing, everyone's talking past each other. Nothing's really getting solved. And so you have to start, for me, from first principles of, if we're going to talk about healthcare, let's be really concise, precise about what the words mean that we're talking about, so we can build upon something.
Are these two separate systems, or is there a Venn diagram where is there an idea or part of private medical that maybe you wish the rest of traditional medicine could steal or adopt? Or are they fundamentally kind of opposed to each other?
I think they're fundamentally opposed to each other from an economic model
Yeah,
perspective. So, and before I go into that thing, I want to go back to what we were talking about earlier: is health
sure.
insurance. Insurance isn't healthcare.
Yeah.
Um, so, what is insurance? It's a financial instrument, right? It's a hedge. It's a financial hedge against unforeseen catastrophic loss. So, health insurance kind of like used to be, you would pay your doctor the couple $100 or whatever it costs in real life. Like, you go to Starbucks, you don't have Starbucks insurance, like, to buy coffee. You would go
Yeah.
see your doctor. But if you broke your leg or had an appendicitis or needed to, your insurance would pay for the big expensive thing. So now what happens is they folded in primary care into the big expensive thing. So just to be super specific, a primary care doctor visit in 2026 for a new patient visit, not a physical, which may be $350. That's the rack rate, but a primary care doctor visit for a new problem, medium complicated, let's say it's 200 bucks,
Yeah.
right? A follow-up visit, maybe like 75 bucks. Again, these are 15-minute increments. So if you went to see your primary care doctor for an annual physical for 350 bucks, right? And you saw them 50 times in a year at 200 bucks, right? You're still under $10,000. No one sees their primary care doctor 50 times a year, especially with my chart and emails and texts, right? So primary cares are the most expensive people in the food chain. They are the front door to the food chain, and they're the ones that direct you to everybody else in the food chain. Primary care should never have been glommed onto a catastrophic insurance thing. So this is like a fundamental oppositional thing. So what is private medical? Forget about the cost of private medical. What does it represent? It represents, I'm going to build a different kind of primary care practice. I'm going to say, look, I could charge you on a fee-for-service basis. Now, the problem with the fee-for-service basis is the sicker you get or the more I see you, the more money I make, right? There's nothing
Yep.
wrong with that. Lawyers do it,
Yeah.
accountants, everybody, it's just a thing, right? But there's a tinge of an incentive problem there, which is real. But the concierge model is, hey, pay me X number of dollars per year, right? Enough that like if you did 50 visits, like it's still rational, but even though you would never hit that number, you pay me and that's all I'm going to make, right? And if that's all I'm going to make, then the two variables that come really important are both, well, they always are time and money, right? And health. So you have time, money, and health. These are the three variables in your stew. And so if you ask the doctor what's really important for like their soul food, it's healthy patients that are happy patients or people that aren't suffering. Maybe the other side of it is that
Sure.
people aren't suffering. So if that's true, then what do I want as a doctor? I want my patients to not suffer and be healthy. And what do I need to do to get there? And if I'm only paid once per year to do that, then I'm motivated to design a system around thinking about your future. Because when I think about your future, I'm also thinking about my future. Because
Yeah. There's the alignment right there. Yeah.
so there's the alignment. Because if you're sick all the time, I'm spending all this time fixing you. And so what's valuable to me is your health and my time. I'll put money as number three if I have to stack rank those things. So fundamentally, I have to then build systems and processes around thinking about your future self. I have to build educational conversations with you about, let's talk about in a year from now if we don't do anything about this. But ultimately, I can tell you stop smoking, it causes cancer. You're not going to stop smoking. But if I really kind of understand why you smoke and understand what your goals are, like you want to see your grandkids graduate high school or what, we can start framing why the habits you're doing now are going to prevent the things that you want. And how do we co-develop strategies? How do I advocate for the side of you that's not advocating for yourself?
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. I'm curious, Jordan, if you feel like because of your incentives and payment model, is trust an issue with your patients it would seem like it's easier for your patients to trust you more than somebody working at a health system or for a private equity group or something like that, because like you said, you are aligned. And I think that's the other big red flag I'm seeing in the past few years is just it feels like the trust in physicians has really fallen in the past few years.
Yeah, well, I think as soon as you talk about trust, and by the way, I just posted a three-part series on trust on my Substack. Don't listen to me. I'm just shameless pitch, but I think it's one of my better things I've written on. And so trust is like this invisible substance, right? And you can feel it when it's there, and you can absolutely feel it when it's gone. But you can't point to it. So, right. So what is it? And to me, I think what trust is trust is a promise. A promise is showing up, in medicine, right?
Yeah.
And showing up is character, right? And character is ultimately the fidelity of character is what generates trust. So part of, our members of private medical, we're always there. We always show up. But what happens is trust also moves from one person to another. Like you ask your friend what are the three best restaurants that somebody you trust, and they tell you what they trust. You're probably going to like those restaurants
Yeah.
or go to those restaurants. And private medical was built in 2002, and because I didn't know what I was doing at the beginning, and so I built a website that said private medical by referral only. I didn't have an email. I didn't have a phone number. I didn't have an address. It was, and I wasn't trying to be super stealth. And I just was kind of like, I don't really know what I'm doing. I don't want to say too much.
Yeah.
Um, and I'm just going to leave, and I'll come up with a different name because private medical seemed kind of like super generic. And I'll come up when I have money. I was broke. I'll figure out a website. And what happened over the next 10 years, by the way, is that I showed up. I took care of people. They told their friends. People would go to the website and go, wait a minute, and they'd call their friend like, what is this? Like, don't worry about the website. Trust me on this. Call Dr. Shlain. And, and now like there's this whole trust architecture that exists at private medical. And, fast forward 25 years and, again, I can't believe it. That happened so fast.
Yeah,
But
that's wild.
but now like people really trust us that don't even know us because they know thousands of other people have joined
Yeah.
and they, nothing but great things to say about, look, I think all doctors are great. All primary care doctors are smart. They've gone to school. I just give the space and the time to our physicians to ply their trade in a way that makes them like the best versions of themselves. And happy doctor, happy patient, right? Meanwhile, the people in the hospitals and the insurance companies are twirling their mustaches, buying their private planes, and I don't know what they're doing with their money. I mean, look, outcomes are not better in the United States. Costs are going up. What the F is happening here? What, like, and no one's like, people aren't stark raving mad, screaming in the streets, what the hell's going on in here? Because we have a collective action problem. It's state by state, it's county by county, it's insurance company. It's this fragmented, balkanized, like plastic garbage thing in the Pacific Ocean. That's what the healthcare system is. It's just this thing that's no one can wrap their hands around. So it's like, can you fix it? Everyone's excited about AI fixing it. I'm here to tell you, like, if you really want to be honest about fixing it, then you have to ask yourself, well, where do you start? Where's the highest leverage? You know, and then
Yeah.
you go, well, the highest leverage is probably the politicians. That's really hard to do. So I
Yeah.
can't do that. So the next way down is maybe the insurance companies. Well, that's kind of a cabal. Like, and you get down to it, there's like, what are you gonna do? Add AI to scribes, and all of a sudden you saved 10% of efficiency. But by the way, that 10% didn't lower the cost; it just went into the pockets of the AI company.
Yeah.
So so all this talk about AI making things better, it's just going to make more money for the people that are. They're not going to lower the cost. It is only going to just redistribute this stupid amounts of money that are going to inefficient, truly bad, inefficient things to actors that are twirling their mustache and just raking in the loot. It's awful.
Well, and
So,
the thing that is within the sphere of influence, sphere of control of a physician is changing the way that you decide to practice medicine.
but when you're in a box, whether it's private equity, hospitals, insurance, whatever it is, and you lose pretty much all of your agency. Here's the formula. Here's the drugs you can use. Here's the protocol that when you put it in your chart with AI now, it's gonna say, well, maybe you should do this and maybe you should do that. But what the AI doesn't know is like all sorts of context. I mean, it's getting better. I don't want to say that I'm a big AI fan. Let me state for the
Yeah.
record.
Yeah.
I've got some projects I'm working on that I think are super cool. Um, and I think AI is going to be a big boon for the profession if and only if it gives doctors back agency.
Jordan, I want to ask you a little bit about how you see concierge medicine and just that term. Like, where did that term concierge medicine even come from?
So you talked about it at the top of this. So the very first day that I quit my job from this doctor who kind of screwed me out of the, hey, work here for a year and then I'll retire and you
Yeah.
can have my practice. Well, that didn't happen. I walked up to a concierge, you know, and I was the doctor to the Mandarin Oriental Hotel. And I went to all these hotels and, I became the doctor so all the concierge would call me, it was called San Francisco On-Call Medical Group. That's what it was called when I started it. So I don't know that there's any moment in time that it was deemed concierge medicine, but I think it probably had something to do with like, oh, he's the doctor to the concierge,
Yeah.
and he does medicine like a concierge. Now, the thing about a concierge, just to be really clear, and we're very explicit at our practice at private medical, is like we are not a medical valet. We don't always say
Yeah.
yes. You may tell us what you want. We're going to sit down and tell you what you need, right? I mean, I'm not going to be prescribing all these crazy things because you want them and because you're paying me. That's not how it works, you know. And so we have a kind of a general thesis of this is a mutual respect club. We're going to treat this as like we're professionals. And if you bark at me and yell at me and and lord over me because you paid me, like try doing that with your insurance company, pal. Like
Yeah.
how's that? So we really try to foster healthy relationships because as you know, or maybe you don't, but like the number one trick in the longevity story is get rid of people that drain your energy in your life. Foster good relationships and you will live longer and you will live healthier. You will live better. So we try to like engender that actually internally. But so I think that's maybe where the name came from, concierge medicine. Sometimes cringe at it because I
Yeah.
feel like it's taken from hospitality. Now, I always try to steal things from other industries that I think are really good experiences that they offer and bring them in. So that's why we kind of talk about more membership-based medicine now,
Yeah.
membership-based primary care. It just feels more natural. But fast forward, I've been fostering and trying to show other doctors that want to just have their own practice and live their life and be the doctor they always want to be. You don't have to charge what I charge. You can charge whatever you want. And so the question is if I told you, and by the way, concierge prices there's like 25,000 of them in the United States right now, and they range from 2,000 a year or even less, I mean, there's some that are 200,000 a year, which is like insane. I don't know why, but, and we could talk about the difference between performance-based medicine and performative. I think a bunch of ultra wealthy people now want like every bell, every whistle, whether it's needed or not. And I think that's a whole other VIP syndrome drama. But when you get down to the low end, you can take a doctor and take care of 500, 700 people for a couple $1,000s a year. And great. And you still have your insurance for the, oh, shoot, the car accident, the appendicitis, the expensive specialty drug, the ER visit, pick the thing. But then you have somebody that's in your corner at all times to help you advocate for you and navigate the system for you. So I do think that this is a model. And the New England Journal article that you reference, like I thought I was super nervous to be in the New England Journal because guess what? Like that is the most left-leaning, healthcare for the people. And by the way,
Yeah.
everybody gets this stuff. Like, but I don't believe you can separate out and make like healthcare is purely, I'll say socialist just to be provocative,
Yeah. Sure.
purely egalitarian and socialist, but housing isn't, food isn't, transportation isn't, you know, education isn't, but healthcare is different. Well, actually, if you don't feed somebody, they're going to
Is
die.
it? Yeah. Yeah.
Right. So I
Yeah.
think all of these things have to be looked at through the lens of nuance. And I do think that if I was going to construct a new system, I'd say insurance is that. Primary care, should go buy their own primary care, let
Yeah.
doctors run practice, let businesses start and prove that they can deliver on the promise. And if you don't like it, you can leave and shop around. You can't really do that right now. There's no market. I mean, there's becoming a market for concierge medicine, which I'm happy about. Um, But now the PE firms are trying to come in and buy all these concierge practices, which I'm like, dear Lord, not
Yeah.
here we go again. And so I'm trying to coach everybody, like, be careful.
People ask, direct primary care doctors this, concierge doctors this. Some people worry that concierge medicine, direct primary care, whatever, creates a two-tier system. In your world, in your mind, is it a solution that could apply broadly? Like, would it be that we just have more doctors who are currently subspecialists move into doing more primary care because it becomes more aligned and enjoyable and
I mean, I
it's as
think,
lucrative? What do you think about that?
um, so I want to be careful about the concept of two-tiered. I
Yeah,
think
sure.
because that's fraught, and it's
Yeah,
loaded, in a lot of ways. Oh, the haves and the have-nots
sure.
versus, hey, I need to get to the airport. I can take public transportation or I can take a limo. Is that a two-tiered system?
Yeah,
I mean,
right.
you both got to the airport, so two-tiered doesn't mean you both didn't get what you wanted, right? To me, two-tiered feels like somebody got something and somebody didn't get something,
Yeah, sure.
right? And this is like the nuance of, like, language again, and I'm a freak about these things. There's a much bigger question underneath the question that you just asked. How much healthcare is really needed in person? Number one, right? How much healthcare is really needed not at home? So, like, I believe that 90% of all healthcare could be done by email, text, and Zoom.
I would
Maybe
agree
not.
with that. I would agree with that
Maybe
generally.
80
Yeah.
to 90.
Yeah, sure.
But the systems in place right now, hospitals are basically REITs, like a real estate investment trust, which is basically, so they own real estate, and the real estate is hospitals, and the hospitals have tenants, and the tenants are doctors, and the doctors pay rent. I also think that 90% of all healthcare is going to move to the home in the next 10 years. So all the blood tests, you put a patch on, you'll be delivered, you put it on, send it out, you know, you need an infusion, they'll come to your house and do it. It's just
Yep.
like they will find the efficiency in the system. So I think this is all slowly starting to play out. Now you have AI and agents, and people are trying to become like the masters of their own healthcare, which is a good idea and a bad idea. So I don't know that we should take specialists that might be needed and turn them into primary care doctors, to answer your specific question.
Yeah,
I think nurse practitioners, I think a lot of doctors that, like, there's a lot of doctors that retired because of Epic, right? They
sure.
retired because of EMRs and coding and billing and burnout. Like,
Yeah, my dad just retired last year because he was sick and tired of dealing with Blue Cross and Blue Shield, but he could keep practicing psychiatry for another decade if he
right,
enjoyed it.
right, right. But I think the fundamental thing is, how do we say, like, look, primary care should not be based on insurance. And by the way, well, what about the poor people? Great. If you can't afford the $2,000 a year to pay that concierge doctor or that membership doctor, then the state pays them. But it's still, that person can leave this practice they don't like it and take their $2,000 and go to the next guy. So you have to create, like, I'll say competition, but really what I'm talking about is who can provide experiences that generate good outcomes, because now we can measure them much more accurately with all this, the AI and wearables and data and stuff like that. But it's ultimately about the experience. How do you make somebody feel while they're getting good health? And when you combine those two things together, it's magic. And it's not expensive. It is not expensive compared to pick anything else in healthcare.
Well, and I like that you just said, how do you make somebody feel? Because I think generally speaking, in the larger healthcare system, in some ways that is distilled down to a Medicare questionnaire about, like, were you happy or not. But in other ways, like, doctors are the original influencers. We you don't go to somebody's house and force them to take their lisinopril and, like, throw it in their mouth and say swallow, swallow, like you do a kid. Fundamentally, physicians, you have to the way you
Inspire.
get your
You have to inspire
you have to
people. But
inspire
you
and
only can inspire through
convince people.
education.
Yeah.
But you can't. There's a great book called by Dan Pink called "To Sell is Human," and what he says is, like, a lot of people think of sales as, like, kind of gross. Doctors think sales is gross, but what you just said is, like, I'm trying to sell you my idea. So and so I'm going to go into all the techniques that a salesperson to sell a car would do to get you to take your antibiotic or your blood pressure medicine.
Yes.
So I do think it's like trust, inspire, follow up, right? And follow through. This is not a hard formula.
And those are all, to your original point, those are all character.
These are all character, and I think every doctor wants to see their patients have good outcomes. You sleep better at night knowing that your patients aren't suffering
Yes.
and they're getting what they should get. the basic fundamentals. Look, I got a patient that needs a liver transplant right now. I don't know if they're going to get it, because that's a whole separate conversation.
Yep.
But they're in line, and there's a process, and it's transparent, and I hope they get it, right? And I hope they make it to get it.
Yeah.
But so medicine is like, I mean, there are some dark, gnarly places about being a doctor where you have to oversee like these like crazy situations of people suffering. And so when you see it and it can't, and it can't be, you can't do anything about it, you can at least take solace knowing that there's a lot of people that you can do stuff about and you
Yeah.
are doing stuff about. And I think that's the moral injury that doctors are suffering. And I hate using that term, but I think it's accurately descriptive, is like, I want to help people and people won't let me help people.
Yes.
And that causes like existential angst that is like sandpaper, on a wound.
Yeah. Yeah. I couldn't agree more. It's that split between I dedicated all my life to be able to help these people, and I know how to help them. And then you're telling me I'm not supposed to, or I'm not allowed to,
Or I
or
can't, or it's gonna
yeah,
cost too much
yeah,
money, and, like,
yeah.
we know it doesn't. We know everyone's profiting off this thing that, like, costs $2, but you're gonna try to sell it for 2,000, and, therefore, they're not gonna get it. So, I mean, I know there's, like, so much more to talk about, but we're coming
Totally.
up on time, I think.
Yeah. Jordan, maybe one last question.
We're gonna have to do a part 2 of this because
Oh
there's
my God, I know.
so much more to talk about.
If you could permanently eliminate one thing from healthcare tomorrow, what would it be?
If I could permanently eliminate one thing in healthcare tomorrow, I would eliminate health insurance covering primary care. I would separate these 2 things. And I would like to eliminate the insurance companies having a complete monopoly over health, over medical care.
Well, Dr. Jordan Shlain, we need to do a part 2. Yeah, we could talk for another 3 hours. Jordan, I do want to plug your writing because it is so good. jordanshlain.substack.com. It's called Don't Listen to Me. You write at least once a week, like a very long,
N Well,
thoughtful, great essay.
so I've been told that they're too long. I do like to write, so now I'm trying to make them like 3 minutes, each. So I've shortened them, and turned them into multi-part serieses. So like this one on trust is a 3-part series. They're 3 minutes each. I want people to think differently, not because I don't want to be prescriptive about what people should do. I think if they can think differently about a problem and get more nuance and context in it, then they have the tools to like engage their communities and their worlds a little bit better. So thank you for the plug.
Well, Jordan, it's been a pleasure. Yeah, we've got to get you on the calendar for part 2 already. Thank you again for being here today.
Hey, it's been a real pleasure. I love, as you know, I'm passionate about these topics and I love talking about it.
Totally. Thank you, Jordan.
All right.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.